but if you want to, I'm going to introduce Joy. So Joy Rhoden. Rhoden it's my pleasure to welcome you today with us to MaineHealth Public Health Grand Rounds. Joy brings to us a career that sits squarely in the intersection of health equity, policy, and systems change, which makes her an ideal voice, really, for the work that we care about here in Maine and across our region and the country. Joy currently serves as the Senior Vice President and Executive Director of the Division of Health Outcomes and Care Transformation at the American Hospital Association, where she holds broad oversight for the American Hospital Association's priorities in health disparities and community health, assisting hospitals and health systems on their journeys to transform care and improve health outcomes for all. Before joining the AHA in 2018, Joy spent almost 2 decades at Kaiser Permanente, mostly out west and some in DC as well, in the LA area and then in DC, ultimately serving as the senior health policy leader in DC, where she developed deep expertise across a wide range of policy topics, including drug pricing. Joy holds dual master's degrees in social work and in public health, as well as a bachelor's degree in psychology and sociology from Wesleyan University. That combination, social work and public health, tells you something important about how she approaches this work with both systems level rigor and a commitment to the people those systems are meant to serve. So please join me in welcoming Joy Rhoden. Thank you, Joy, so much for
Thank
joining
you
us
so
up here
much,
at Maine.
Dora. Appreciate that warm intro. Thanks for the invite to have this conversation with your audience today. I was asked to really cover with all of you what the AHA is doing to encourage our hospitals and health systems, our members, to address health disparities that we know continue to persist in our sector writ large. And so I'm going to do a deeper dive around that. But I just want to acknowledge that, the good work that all of you are doing on behalf of the patients, the families, and communities that you're serving, and that we certainly are counting on all of you to continue to provide that leadership that the communities so badly are looking to you to deliver on. And so we thank you for your being boots on the ground. We've seen a significant pivot, I would say, if you want to bring up the slides. When I talk about the current state in the last year, the next slide, yes, thank you. We can go back to that next former slide. Following the president's EOs around diversity, equity, and inclusion, we really saw a big effort by many of our members to really realign their language. And I would say we saw that change at both the departmental level as well as at the individual titles across different leaders who are charged and who are accountable for leading this work in hospitals and health systems. But we saw a real commitment to mission, and where organizations were tethering their actions to their mission. And at the end of the day, if you can get your workforce to align around the mission, then that's certainly a really good starting point. So it's a mixed bag, I would say, in terms of what from this perch, as I'm looking across the country, where folks are doubling their efforts in this space, and where others are still trying to figure out what it is that they can do to stay the course. So I would say that our key message to our members who are focused on addressing disparities is to really look at their work from a data perspective. It's not just good policy. It is how we actually move organizations and our workforce. How do we activate the workforce? And how do we move from admiring the problem to actually taking steps and stop talking about it in anecdotes, but to actually do something to mitigate around these gaps in care and outcomes, rather, that we're seeing across different patient groups. And so we really want to close what we used to talk about at Kaiser Permanente back in the day as the knowing doing gap. Um, and data provides that opportunity because it's objective. So when you look at the differences in health outcomes, you can then develop plans around those gaps. And I would say we had a recent all-team meeting, and my CEO described data as the vehicle to ensure more targeted use of resources, whether it's dollars and cents or human capital, personnel, resources. And I think he's right. I think that's right. That whatever we're doing ought to be data driven and data informed. Next slide, please. So let's talk about this division of health outcomes and care transformation at the AHA. You'll see here that the charge as a division is to influence sustainable change across America's hospitals and health systems to advance the conditions that produce health for all. And that tethers very closely to the AHA's vision. Our vision statement is that the AHA's vision is of a just society of healthy communities where all individuals reach their highest potential for health. And so in that vision statement, you see that the goal is health, not health care. And so, again, we recognize that doing this work is going to require strong collaboration, both internally here at the AHA and externally, engaging our members through roundtables and committees to gather that field intelligence that we need to inform our work priorities on behalf of hospitals and health systems. We have nearly 5,000 hospitals and health systems that are our members, which is the vast majority of hospitals in this country. And so we want to lend our voice to a range of topics through thought leadership. So speaking at conferences, doing grand rounds like this one, writing blogs, issue briefs, webinars, podcasts. We're on the circuit. And our members really do rely on us for the development of what I like to refer to as actionable tools and resources, right? And I would argue that our sweet spot at the association is really our convening power. That's our superpower, where we can bring together all of our members who are working on a variety of topics. And I'll talk a little bit later about our upcoming conference that's laser focused on addressing disparities. Next slide, please. So this slide gets us a little more weedy into the tactics and the ways in which we seek to influence our members to take actions. And so I want to call out at the very top in the green section some words that I think really illustrate the action-oriented nature of this work. So you see words like empower, drive transformative change, scaling leading practices, with the goal of improving health outcomes for all. Those are pretty audacious goals that will require deep engagement from, again, all of our members and other actors and stakeholders in the healthcare ecosystem. And I want to reiterate that the actions that we're encouraging our members to take are really anchored in their organizational data. It is important to understand your data, your organization's story from a data perspective. Patient level data, community level data, that is truly the starting point to do this work. Otherwise, you're kind of just throwing darts in the dark. And so it is that systematic, the first bucket here talks about the systematic collection and the standardized way in which we ought to be collecting data to then interrogate those data, to then have those data guide our interventions and the investment that a hospital or health system makes in this space. My team has also developed a whole body of work around care delivery transformation, and that's the second bucket here. New care models that are emerging that we know have the potential to transform how care is delivered and how care is being received by patients. And so the examples include tech-enabled care, right? How do we leverage technology? And how are we careful in deploying those technologies to make sure that they actually don't exacerbate disparities? Because if they're not deployed in a responsible manner, they do have the potential to do just that. Other concepts and constructs such as interdisciplinary and multidisciplinary team-based care. How does that have the potential to transform the care experience? Then getting back to the actionable tools and resources I spoke about on the previous slide, the third bucket, our job is really to elevate for the field those evidence-informed practices that where folks have outcomes to show for them, right? So they're measurable, they're sustainable, they're scalable. And how do we elevate those so that others can learn and don't feel like they're starting from scratch in this work? And then the fourth bucket speaks to the fact that no one organization has all the answers, right? And so doing this work in partnership, and I use the word partnership loosely here because there are some partnerships that are tightly coordinated, where there are financial MOUs and there might be some exchange of funds. And then there are looser partnerships where we're elevating each other's good work. But at the end of the day, it is important for us to do this work coalition style. That is how we're going to drive practice adoption across the field. And so we're always here at the AHA seeking to identify trusted messengers to expand our reach. And then lastly, the last bullet bucket on the right, that fifth bucket, speaks to the fact that all of the work that we do here at the AHA is in support of our advocacy and our policy priorities. And so that is certainly true for the work that this division is leading. Next slide, please. So represented on this slide are the four verticals that reside in the division and the cross-cutting considerations that we apply to the work. The first three, I would say, are ongoing streams of work: maternal and child health, care delivery transformation, the social drivers of health. Those are not new topic areas for us. Over to the far right, the brand new work that we're developing is in this health disparities space. Disabilities is one of our subject areas, living in that disparities space, because we know that individuals who have both unseen and seen disabilities certainly experience the healthcare system in a different way. We're also focusing on health literacy, right? And the importance of that and the role it plays in one's ability to engage with their care team. One of our major deliverables, and you also see prevention and wellness, right? How do we prevent illness before it even occurs? How do we orient the healthcare system to focus on well care and moving further upstream? One of our major deliverables for this year focuses on helping our members to understand that addressing health disparities is actually a business imperative. It impacts the organization's bottom line. And so it's not just a moral, feel-good thing to do. It actually has some financial implications. And so we are developing a guide for the field on the economic impact of disparities in health outcomes. And we hope to launch and release that this quarter. So please be on the lookout for that. But again, pick a topic. If it's maternal child health, we're thinking about it from the public health perspective, from what's the innovation that's happening in maternal and child health. And I'll talk a little bit about that later. What are some of those still outstanding research questions that we need our health services researchers to answer for us? Who are the partners in this work? And so this is how we are approaching our work in the division. Next slide, please. This is just a sampling of work that is currently in the division's portfolio. You will see here that we have member groups. We've got a Health Outcomes Advisory Council. We have the Maternal and Child Health Committee. We have our grant-funded work. We currently have a grant from the Commonwealth Fund to look at rural maternal health. And we are coming to Maine. Our next site visit in June is in Maine. We have our upcoming conference, the Healthier Together Conference, May 12th through 14th in Dallas. And so this, again, is just a little bit of what we're up to here in the division. Next slide, please. I want to point you to our new webpage where you can peruse the resources that we've built out thus far. It houses our care delivery transformation work, a whole suite of resources in the maternal health space, including our Better Health for Mothers and Babies initiative. There's a section on our fee-based custom innovation summits that we're happy to provide to any health system out there. We've also been working through our state hospital associations to put those summits on in different states. We're planning to add our social drivers of health framework here any day now. So we will continue to build out this page. So please check back often. So next slide, I want to pivot and do a deep dive around some of the topics I just surfaced for you. But before I do that, are there any immediate questions about the Division of Health Outcomes and Care Transformation that I might answer? Okay. So maternal and child health is almost, I would say, next slide, please, the poster child for health disparities, because we know that this has really felt, I know for me and many others who work in this space, it sometimes feels intractable, right? It's one of these vexing challenges in healthcare where we can't seem to make enough headway and progress and close the gaps between. We just celebrated Black Maternal Health Week 2 weeks ago, and the data are still, the statistics are still disturbing, where Black women are dying at 3x the rate of their white counterparts. And it's not, when you control for socioeconomic status and educational level and income and all of that, it just doesn't seem to change the outcomes. And this is actually a global problem, right? So it's something that many countries are grappling with. But we know that 80% of all pregnancy-related deaths are preventable. And so I just have to believe that if we were to apply the right dosage of intervention in this space, that we will begin to see significant improvements. And I want to call out that it's not just the deaths, but it's also the morbidity related to pregnancy and childbirth that is of concern. So whether it's that gestational diabetes that then lingers in the postpartum period and becomes full-blown diabetes, these are also really concerning outcomes. And so we are, on the next slide, please, working alongside our hospitals and health systems through our Better Health for Mothers and Babies initiative. We've got this four-legged stool that you see here, where we've built out resources for each of these component parts. So the first is around data. As I've mentioned, it's really the starting point in this work. And so how does an organization collect data around their maternal health outcomes and then develop quality and patient safety metrics to guide their efforts to reduce the gaps? Second, is really looking at those gaps, right? And considering the root causes of some of those disparities and then going after them in a coordinated way. The third is ensuring that whatever solutions are being developed, that we've actually brought in the patient voice, the community perspective to help to co-design and co-create those solutions, so that we should be bringing in folks who've got lived experiences to help to design what those solutions look like. And then last but certainly not least, we believe that the workforce is really an underutilized resource in this work. And so that we know there's some data that demonstrate that if the workforce is activated and engaged to see themselves as influencers, that it actually reaps better HCAP scores, for example, right? Your patient satisfaction scores go up when the workforce themselves feel like they are being included, their voice is heard, they're seen, they're respected. And so if we can use that lever to begin to do even more meaningful work for our moms and babies, we'll be well on our way. Next slide, please. So We're now really thinking about what are the promising practices and where's the evidence leading us when it comes to addressing these disparate health outcomes across the care continuum. And I actually want to go back to the team and challenge us to think about the preconception phase. If you're thinking about this more broadly as women's health. So for those young girls and young women who have a desire to experience pregnancy, how do we educate them on what it takes to prepare the body? This is a full-on whole system impact to when pregnancy, when one decides to become pregnant, it impacts all the body's organs. And so how do we ensure that we're preparing young women who want to experience birth so that they're entering that prenatal phase in a good physical and mental health in as good shape as possible, both physically and mentally. And so you can begin to see some of the strategies that are emerging in the prenatal space around mobile OB units for some of our more rural and remote areas. In the labor and delivery space, one of the big innovations, we're seeing more and more states through their Medicaid program. And we know that 4 out of 10 births in this country um, are to Medicaid moms. And so we're seeing more Medicaid programs covering doula services, right? As the evidence has shown that having a doula actually improves outcomes. And we're also seeing regional planning as a shared services opportunity, again, in many rural contexts where it's really hard to have an OB/GYN in each hospital when maybe the volumes are really low. How, as a region, might a group of hospitals come together to provide these shared services? And then in the postpartum period, which is where most of the deaths are occurring, what are the opportunities to leverage technology to monitor mom at home? What are the opportunities for CHWs, community health workers, to be an extender of the healthcare workforce and to go in and provide home visits? And so these are just some of the ways in which we're seeing some innovative practices emerging, bubbling up. Next slide, please. So we actually, I mentioned earlier, our grant, our Commonwealth Fund grant that is in play, it actually expires at the end. It ends December of this year. And the name of the grant is Opportunities for Innovation in Rural Maternal Care. We've been engaged, a team, in a lot of interviews and conversations with our members across the country, again, trying to surface these new and innovative ways in which people are thinking about impacting the outcomes in maternal health. I had the privilege of joining the team earlier this month on our first of 3 site visits. The first one was to the Mississippi Delta region. And I will tell you, it was eye-opening, both culturally and around the maternal health care, because it is a maternal health care desert in the Mississippi Delta, in that particular region between the Yazoo River and the Mississippi River. And I mean, it's the challenges are really profound. And I've always said if we can solve many of the challenges we have in healthcare in the rural context, we will have solved them for healthcare writ large, because we can take some of those learnings. When you're in a resource constrained environment, you are required to be innovative and to come up with creative solutions. And so if we can learn from our rural partners and our rural members, we can then apply some of those learnings in other urban and suburban settings. So I will encourage you to keep an eye out for the learnings that we will be packaging as a part of this grant, and we will be sharing broadly across the field, really, hopefully, a menu of strategies that folks can then lean into and figure out which ones would be most applicable to your local context. Next slide, please. Also, a lot of enthusiasm around a collaboration that we have with Epic surrounding postpartum hemorrhage. We have several of our members, I want to say about 100 members who've joined a collaborative, and that may be on the next slide, but really learning how to respond to postpartum hemorrhage using Epic's tools. And one does not have to be on Epic to leverage their Stork in obstetrics information system. And members of my team are doing this work in partnership with the AHA's performance improvement team, who they're the experts in change management. And so jointly, we are leading this effort to help our members assess a mom's risk for hemorrhage, really looking at the assessment that's needed both during childbirth, the delivery period, but also in the postpartum period, and developing guides to support clinical decision making. Next slide, please. You can see here our goal for the collaborative, which launched just a month ago with 100 hospitals, as I shared. I know that there's a session planned on how to use a quantitative blood loss calculator, which in concept sounds simple, but it's often challenging to get buy-in, and to really implement this at scale across providers. Many folks think they can just look at a mom and kind of assess visually what's happening and know how much blood loss there is. And so we kind of want to shift that thinking to using the actual tool. Next slide, please. So we are still open for business. This collaborative is on a rolling basis, so we are still encouraging folks to join the community. We're going to be pairing up peer-to-peer learning opportunities with those who have implemented the tools, with those who are just starting, to support one another in this journey. And you can see how the approach is that there will be monthly events with SMEs. There are monthly office hours with AHA and EPIC, monthly office hours with our Patient Safety Initiative team, and again, the peer-to-peer virtual forum. The next slide details the types of organizations who are joining this collaborative. And I would imagine many of you will fit into some one of these categories: rural, critical access, hospitals without labor and delivery services. So where folks are, moms and birthing people are showing up to EDs. And so how does the emergency department respond to these obstetric emergencies? And then the roles of the folks who are a part of this collaborative. So again, bringing this to your attention so you know that it is still available for you to dive in. The next slide, I'm going to pivot from maternal child health to talk about care delivery transformation. We know that there are a multitude of factors that influence how care is designed and how care is delivered. We certainly want to see care that's designed with the patient at the center. That really, that's how our care teams are working. Many of our members are really reimagining care to deliver care across the lifespan. So really taking a more longitudinal view about the needs of their patients. And so in some instances, folks are leveraging existing tools, they're integrating new technologies, but again, in many cases, we're also seeing our members rethink team-based care to ensure that it's truly interdisciplinary and that they're really leveraging all the strategies that might be available to design and implement care delivery models that enhance the healthcare experience, both for patients, but also for providers. We really do care about our providers and impacting their work life as well. Next slide. So this is a visual of, I'm sorry, can we go back one to the framework? This is just a visual representation of the care delivery transformation framework and the components of a healthcare ecosystem that can really facilitate the development and the implementation of these innovative care delivery models. And so I would just say that those four foundational principles really guide the efforts and should guide how folks are thinking about their care delivery strategies. Are they person-centered? We certainly want care that's safe and high quality. It needs to be accessible and affordable, and it should be coordinated again amongst all the providers who are involved in that care. And then right above that, you see the key common infrastructure components that then support the care delivery strategies. And then you see that bridge from clinic to community, from hospital to community, right? Really highlighting the role that it's a joint effort, right? We again can't do this alone. We certainly need to lean on our community partners and others in that ecosystem. Next slide. So because we know it's been well documented that healthcare is shaped by far more than clinical care, hospitals are increasingly looking upstream, and they're collaborating with others to begin to understand. And this is where my social work training really gets put on full blast, because I was trained in the biopsychosocial model that no one raises his or her hand and say, I want to be a patient today, right? We find ourselves in occupying that seat as a patient. And it's usually at our lowest point, right? And so a patient is more than a patient. They're employees. They've got a role in the workforce, a role sometimes as a mom or maybe a caregiver, a friend, a sister. There are many hats that people wear. And so we have to do a better job to respond to the non-medical needs that our patients present to us with, recognizing that there are all sorts of other factors that are going to impact one's ability to pursue their health goals. And some of those factors are structural in nature. And that's that far outer ring where you see the support structures and the role of the hospital to really be an advocate with others, whether it's with public health agencies, it's talking to local elected officials. What are the needs of that community? And then if you move one layer in to the community-based initiative, it's recognizing that, the hospital, again, we tend to, in most of the communities in which we operate, we wield significant authority and power. We tend to be the largest employer in many communities. And so how can we actually leverage that position? I think we're well positioned to use our convening power to bring other stakeholders, again, the social service agencies in the community, the transportation authority, the school board, the housing authority, and community-based organizations to design for the health of a community. And so that's a really important role that a hospital can play. Because I just want to call out that we fully recognize that a hospital, the medical care dollar cannot be split in this many different ways. And so we're not asking that our hospitals do this alone. This is truly more about leaning into that leadership opportunity to drive meaningful change on behalf of the individuals, the families that you serve. Next slide, please. So I've done a lot of talking, and I want to pause here before I provide some division updates to really invite you to help inform our efforts here at the AHA. When you think about this association really representing the field's interests, but also as a catalyst to drive meaningful change across the healthcare system writ large, and you're interacting with our resources and our tools, I would love to hear from you, what really, and I don't know, Dora, if you want to facilitate this part, what are those really best approaches that we can employ to get your attention? Is it when we show up with the data and the evidence, right? Is it having more peer learning opportunities? Is it really our sweet spot around our policy and our advocacy work? What is it that you think is going to be most impactful in this space at this time to move the needle around this body of work? And I just want to pause there and collect your insights.
Great questions. because I'll start off. I think I would say all of the above to start out.
Of course.
And I think about the issue with maternity that I serve on the AHA's Maternal Child Health Committee, and we've been discussing quite a bit of the issues that you mentioned. And I think about that the data and evidence have been so important. What AHA has brought forth nationally into the table, and the many tables. Also, those meetings, I've learned a lot. I know Julia Resnick convened a meeting, I think last month, of by regions. So I was on a regional meeting for maternal health issues, and it was fascinating to learn what other hospitals in the region are doing. Region meaning, I think it was most of the East Coast. But then also the practical tools, learning from each other parts of this country and other hospitals, what they're doing to address issues. And of course, policies are so important. For the maternity issues. So yeah, I can't imagine moving forward successfully without any of these. Seems like very important. But I know there's a lot of other people on the call that may have some ideas too of what's there. So feel free to raise your hand or add to the chat. I know people oftentimes are eating lunch while they're here, so I don't know.
Okay.
Well,
it's something I just want to posit for you all to think about. We certainly want to be responsive to providing information in a way that's actionable and that is digestible and that's most relevant to all of you. So, and to your point, maybe it's not either or, it's a both and. And so, but if we're over indexing on one area that we ought to pull back on, that would also be really good to know. I think we have a hard time figuring out what to stop doing when you think about stop exercises. So, yeah.
Naomi's got her hand up. Naomi, who's our
Hi, I was just writing something in the chat, but I'll certainly unmute. So this has been a great presentation, and your visual, with the bridge between clinical and community. I mean, it really speaks our language here at MaineHealth. And so, on your slide here, what would be helpful to us and to move us into action? I think it's learning from others, because we've often I think we have felt that MaineHealth is a little bit of an island in a sea of other health systems in our emphasis on the clinical community connections, that nexus. So I'd love to, I'm going to dig into the website a little bit, but I'd love to learn more about what other organizations are doing, because we're not super formal with MOUs. Yes, we work with community-based organizations, but we don't always have formal contracts, and Maine's one big town, so we do a lot of work because we know each other, and we have built that trust and relationship. So I'm super curious to learn what you're doing in other like geographies, as we, you talked about community health workers and extending, how can they be supportive of maternal health. We have the same, as you know, the same issues here in Maine. So I'd love to learn about what other folks are doing across the country, so that we can, we talk about evidence-based work, but we also, it's like evidence-informed. What are other people seeing early wins with that we might be able to replicate here? So thanks for this.
Sounds
I'll
good.
put in
Thank you.
plug for the conference this next month in Dallas. And I keep calling it the Healthy Communities Conference, but it's from
Healthier Together.
Healthy Together. That's
It's in the slide deck, Ellen, if you want to pull that up.
It's a great conference, and I'm excited to go next month, and hope others can attend too, either next month or next year when you have it again.
That's right. But it begins to get at your point, Naomi, around how do you learn from what's happening across other geographies, and in particular geographies that are similar to yours. And so that's exactly the reason we're bringing folks together. And it's not too late to register. You can see we've got 5 content tracks. The first, and not listed in order of priority: reducing disparities in health outcomes, leading practices in data assessment and analytics, care delivery transformation, which also Dora will be the theme for Leadership Summit in July. It's care delivery transformation. Partnerships, right, with public health and CBOs. And then last but certainly not least, how are we effectively, it's not just engaging communities and patients, but in an effective way, because I think things like patient and family advisory councils are pretty ubiquitous across our member hospitals and health systems, but are they actually effective? Are we taking the learnings, the input, and how are we then, how does that input change how we prioritize what we do as healthcare administrators? And so there'll be 3 general sessions. Daniel Dawes is going to be our opening keynote speaker. He's probably a household name for many of you. One of the architects of the ACA. He is now at Meharry Medical College in Nashville, Tennessee, as the founding dean for the School of Global Health. And the School of Global Health's mission is to address health disparities. So he's going to kick us off. And then there are 2 plenaries. Day 2 will be focused on care for the disabled population, and day 3 are closing plenaries around AI and its potential to advance pop health writ large. So lots happening at the conference, and we have about 50 breakout sessions. So I would encourage you to, if you're able to make it, to do that. Then the next slide, I think, oh, I had referenced our economic impact of disparities in health outcomes resource guide. And so that is going through, it has actually completed the internal review process. And next up, we are taking it to our advisory, the Health Outcomes Advisory Council that I mentioned earlier on that slide that had the sampling of all of our work. And so that council will take have the opportunity to weigh in on the guide. But I think it's going to be really instructive. I know in many of my conversations with members, especially the CEOs, the question they're asking is, why should I do this work from a business perspective? How does this actually impact the bottom line? And so this is secondary research. It's not primary original research. So that actually tells you that there have been some attempts at trying to answer this question before. But the AHA has not ever weighed in and lent its voice to this discussion. And so we're super excited and we'll have a whole comms process around this, and we'll host webinars when this is launched. And we will also have case examples from members who have been able to produce cost savings or cost avoidance opportunities by paying attention to the disparities that they unearthed when they looked at their data. So this is going to be a really actionable tool. The next slide, I think, is about our Carolyn Boone Lewis Award that we are proud we will be giving next year, July 2027 at our Leadership Summit. But the application cycle will open this August or early September. And again, we're looking at our members who have been able to demonstrate through outcomes that having data-informed strategies have yielded some reduction, they've been able to mitigate in some way, shape, or form the health outcomes across different patient groups. And so encourage you to think about applying for this award. More to come on that.
We do
And
have
I'm
a
happy
couple
to take any
questions in the
questions.
chat. Can you see those?
Oh, let's see.
Let me go down here. What about data regarding unintended pregnancy and drug-affected births? There's a question from in the chat.
So that's probably an area that's been underexplored in our work here at the AHA. It's certainly something I care deeply about. And when I launched my career back in this year's 30 years at a hospital in Los Angeles, a large public hospital, before I went to Kaiser Permanente, And I spent 4 years, and it was excellent training ground, right? Because I saw a little bit of everything come through those doors. Very complex, complicated social picture that are the patients presented with. And I happened to be assigned to the outpatient OB clinic, OBGYN clinic. And I had a few pediatric subspecialties as well, subspecialty clinics that I covered. But I followed the moms from the clinic when they came to deliver their babies. And so, and I one swim lane within that OB population were teen moms. And so I was the social worker for teen moms, and also covered the NICU, the neonatal ICU. And so many, to your point, babies born to who were born with drugs in their systems, right? With moms who were users, had to on occasion engage the state Department of Children and Family Welfare, social services, right? So there's quite a bit of work that I could see us doing around unplanned pregnancies, which is why I shared earlier that I actually want to go back to the team, that slide that just had those three verticals in terms of prenatal, the labor and delivery, and then postpartum. We actually need to go further upstream and talk about preparing the body to become pregnant. And so thinking about using birth control if that's of interest, right? And just really understanding what are the different levers that young adults should be considering as they're thinking about becoming a parent. So thanks for that call out. I will take that back to the team. Can CHWs be deployed universally well, again, if we could, unfortunately, our culture, Ellen, is not always as excited about not seeing an OB trained provider, right? So in the British NHS, for example, right, seeing a nurse practitioner is the norm, or a physician assistant is the norm. We unfortunately can't pick up what's happening in some of these other countries and impose it on the US because our cultural requirements and patient expectations are so very different. But certainly it has been shown that investing in prevention and wellness is actually the way to go. Those countries have better health outcomes than we do, and we spend more, and our outcomes are a far cry from other developed countries, if you will. And so there's some learning to be had from going into homes. I've even heard providers say leveraging telemedicine has been a window into a patient's home where they can actually see who's moving about in the background. And depending on where the patient is sitting, to take the call, maybe they're in the kitchen and they can see, if a cabinet is open, what's in that cabinet. And so there are ways in which having trusted community members in the form of a community health worker it brings a totally different lens to the care team. And so I would advocate all day for CHWs and doulas. I actually practiced as a certified birth doula when I was in LA. And so I do know the value of having non-medical caregivers be a part of that care team. And so I think we should expand the definition of the healthcare workforce to include these other professionals.
That's great. And we've got a couple other questions too. No, and I couldn't agree more with you that quite a bit of literature review of the maternal health literature, and it does point, as you said, including the Commonwealth studies looking at other countries, that a diversified workforce is key. Diversified professionally, diversified culturally, racial, ethnically.
The broadest definition you can use.
Exactly. Right? So thank you for reiterating that. There's a couple of other questions here too related to telehealth. Jessica has one. If you can see that.
I think it's
So
the
we, in a climate where
regulations.
regulation and limiting, how do we continue to advocate for the importance? So we continue to advocate. Absolutely. That is one of our, I'm not sure if you all have seen, it's publicly available, the AHA's 2026 advocacy priorities. Or I can send it to you after this call, Dora.
Sure.
But looking for the flexibility and the waivers that were in place during the pandemic is certainly still top of mind. We've gotten some traction in that space where we are seeing payment now for certain telehealth services that were not priorly in the past. We were not able to obtain payment and reimbursement for. So I think things are directionally correct. The case has been made over and over, and we will continue to advocate for telehealth flexibilities. We do our work, I will say, at the federal level. So if there are state-based opportunities, then I would point you to your local state hospital association.
Great. And there's also a comment, I think, related to that. Carrie Burkett, who is our
state.
She's she is our president of our hospital that's located in New Hampshire.
Right.
She talked about the fact that they can't. Our telehealth hub is mostly located in Portland, in Maine.
Exactly.
So we can't even serve our own patients in New Hampshire.
Yeah, that certainly is an issue for delivering care. Again, all of that was relaxed during the pandemic, right?
Yeah.
You could deliver care across state lines. It's also an issue for our members who have a multi-state presence, right?
Yeah.
How do you navigate that? So,
yeah. And Barbara's got a great question about psychosocial support, which I think is up your alley. And actually, I realize we should be reading these out loud. So in case people are listening to this as a podcast, so wondering how the AHA project integrates psychosocial support, recognizing its protective factor in preventing preterm delivery, and or if you're aware of any evolving uses of technology to build in social support.
So great question. And to your point, certainly right up my alley from my earlier comment about my social work training. We certainly, in our work, think about person-centered care. That's how we describe the work that we're asking, whether it's our nurses or clinicians or docs, whomever's touching that patient, right, from the clinical side, to think about delivering care that is it's going to resonate most deeply with that patient's background, culture, the way in which they receive information. And so it's really looking at all three, the biological, psychological, and the social constructs from which these patients come. And so we apply that model to our work, to the guidance that we're building out for the field. It is certainly a protective factor. The word doula, for example, is a Greek word that means mother's helper. That's what it means. And so for anyone to have a dedicated resource as they're going through delivery who is solely focused on their non-medical needs, I mean, you have to begin to see how that translates into better health outcomes. And so leveraging technology to build in the social supports is something that we've been talking about in terms of tech-enabled care, remote monitoring. We are hoping through this grant with the Commonwealth Fund, again, the team has had over 75 conversations so far. We have had one site visit, Maine is next, and I want to say Montana is the third. Coming out of this whole really comprehensive approach to looking at maternal health, we hope to be able to answer some of these questions. Nothing jumps to mind as a leading example, but we know that, again, this is the direction in which the care needs to be designed around the patient, around the individual and their family needs. And we're certainly going to be surfacing those examples where we find them.
Great, great. Wonderful. And then, yeah, and Carrie also talks about having great local opportunities for training CHWs and doulas, and great enthusiasm from the birthing centers. So that's nice, and OBGYNs. But the challenge of finding funding, I'm sure you've not heard of that before, right?
Right, right.
That is such a big issue. And I know in Maine they're working on it, but I don't know about New Hampshire, but it is, I think, across the country, it is very, very tough.
Yes.
Oh, Carrie, I'm so sorry. I did call you the wrong title before. She's the senior program manager of community health, not the president of the hospital. I gave you a promotion, Carrie.
Promotion. Take it, Carrie. Run with it.
So, anyway,
so what we're seeing is philanthropy. That's what we're seeing. It's grant funding that folks are using, applying for grants, getting those dollars in, doing pilots, and then the challenge that I have with all of that is, okay, so then it's the pilot is successful, and where are the operational dollars then to continue to scale the work? But I would say the vast majority of folks who are kind of experimenting in these spaces with CHWs, doulas, they're getting dollars from philanthropic sources.
Yeah, and it's frustrating, and yet I've been around long enough that I've gone through those cycles of having to use philanthropy and sometimes federal dollars to implement something that's new, evaluate it heavily, show the ROI from a fiscal and or health standpoint, and then you can get usually some kind of reimbursement through value-based care increasingly, or state government, or Medicaid, which is Maine
Care. Through Medicaid, the 1115 waivers. I mean, that's also a vehicle. And as I mentioned earlier, I think 36 states are now paying for doula.
That's great.
Yeah, for doulas.
Right. Well, I think we are at the end of our time. I want to thank you again so much for joining us here at MaineHealth Public Health Grand Rounds. And I also want to let everybody know that we have two coming up in May. We have May 12th, which is now at 10 o'clock, not 12, with Michael Osterholm, nationally known, internationally known infectious disease epidemiologist, who has a widely watched, listened to podcast, as well as a new book out, and several other books out. And then on May 19th at 12 o'clock, back to our regular time, we have Dr. David Higgins, who is a internationally known vaccine hesitancy expert. So he's going to share tips and tools for working with families and communities who are vaccine hesitant. He is a practicing physician himself in Colorado. So we're fortunate to have two upcoming presentations in May, but we're most fortunate to have Joy join us today. So thank you so much, Joy, and we'll see you all next time.
Thank you.
Bye-bye.